Okay, good morning, everybody. My name is Chuck Lahe, and I am a CVID patient and a board member of the Immune Deficiency Foundation. I welcome you to our session this morning on common variable immune deficiency. Please remember that every patient's treatment and condition and diagnosis is unique. So we ask that you just be respectful of others around you at your table, asking questions from the doctors and the responses that we get. Also, the feedback we get from the app, the mobile app, where you can give survey and responses and your opinions to the session is very important. So at the end of the session, please provide your survey. And again, that enters you into the contest to win a gift card. I thought is motivation, but your feedback is what's really important. We also ask that if you do take photos of any of the slides or anything, they're for your personal use only and not to be posted on social media or used for any other purposes or shared with anybody else. Finally, on the table you will find little pencils and 3x5 cards, and I know the doctors will be willing to answer any and all questions that they can. For their benefit, please print large so they can read the questions, and we'll have people running around the room, and myself included, collecting cards and bringing them up to the doctors. So thank you. So it's now my pleasure to welcome you to your PI session on common variable immune deficiency. This session will be presented by Dr. Charlotte Cunningham-Rundles and P.J. Maglione, Dr. Maglione. Dr. Cunningham-Rundles is the David F. Gottesman Professor of Immunology at the Mount Sinai School of Medicine in New York. She's Professor of Medicine and Pediatrics, a member of the Immunology Institute, and directs the Immunology Clinic at Mount Sinai, and is a member of the IDNet Physician Advisory Committee. Dr. Maglione is an Assistant Professor of Medicine in the section of Pulmonary Allergy, Sleep, and Critical Care Medicine at the Boston University School of Medicine. So please join me in welcoming our speakers.
So thanks to everybody for coming. We're going to try to make this a little bit informal, but I have some things that we also wanted to talk about. And if you can fill out some cards, we'll try to sort them a little bit later. First of all, how many people here have been told that they have CVID? That always gives me a thrill when I see it. You have no idea, because you know how it is. Patients always say, I don't know anybody else. I'm the only person in my town. And you know for sure that's not true. They just don't know who that person is nor where they may live. And they've never run into them at the supermarket, so they always feel pretty much left out. So for those of you who don't have CVID, you're probably here with somebody who has low gamma globulins. Could you tell me who you are? So these are all the accompanying family members, which are really so fantastic. And again, it's wonderful to have literally everybody here. I think probably a lot of people here are on gamma globulin, yes? Immunoglobulin therapy. Again, amazing situation, isn't it, that we are in. And things are moving very, very quickly in this area, which I have to say is a little bit stunning to me. Looking back, you think when you're dealing with antibody-making deficiency diseases, you don't really think that you're ever going to understand more than just the basics, give gamma globulin, give antibiotics, and hope for the best. But I think things are moving along quickly, and I'd like to convey that view to you. One way to do that, and I didn't put a slide like this, is in the publication record. There's a place that we look for all the publications. The number of publications on CVID is actually skyrocketing. It's just absolutely a huge number. In 2018 and 19 is higher than it ever was. That's because people are paying attention to what this is all about. Why do those antibody-making B cells just go out of business? So I'm going to tell you just a couple of things about it. This is what we thought we would put together. Before I do that, I have to tell you that Dr. Maglione is in Boston, and he moved there last year. He was at Mount Sinai for a period of time, but he is now really open for business in Boston, and hopefully some of you will live in that area. Because I think, again, the Northeast is a little bit shy, doesn't really have quite enough expertise about CVID, so I do want to mention that right now. So first of all, what's the diagnosis, some of the clinical features, some of the basic treatment, what else, inheritance testing, standard treatment, and then we're going to get into, okay, when you don't really respond that well to gamma globulin, what else we need to know about. So first of all, this is kind of one of those pictures that I actually use for medical students. Gamma globulin is not the only game in town. This is the entire of the immune system here. These are all the cells, starting with that little cell over in the beginning, the little purple one, and that's the stem cells. So stem cells give rise to all of the immunological system. In addition, of course, the platelets, the red cells, the dendritic cells, every other cell has to be born really from this particular progenitor cell. Those are the stem cells that you read about. But the ones that we're talking about really are these guys. And this is the portion of the immune system that's not working very well. And we spend a lot of time talking about B cells, right? B cells are the cells that make gamma globulin. They are the cells that then ultimately become what we call a plasma cell. People with hypogammaglobulinemia don't have enough of those cells, and the ones that they have don't work very well. They don't produce those gamma globulin molecules. So what else about that particular thing? So these cells also require and have a very hard life, and there's another slide I'm going to get to in a while that will kind of amplify that remark. But first of all, you think that antibody-making cells are kind of out here on the limb. They're supposed to do their job. They make gamma globulin. And they also do another trick, which is pretty fantastic if you think about it. People in this room probably had measles, mumps, and rubella immunizations when you were a child, right? A normal, healthy immune system will remember that MMR vaccination for 30, 40, or 50 years. So that's what we call immunological memory. Where does that memory, where is it? We call it memory because it sounds like a neurological thing. Actually, it's in the bone marrow and in the B cells, and in this collective understanding of what the universe holds. So this trick about memory is something which we talk about because B cells that attain that quality, we call them memory B cells. It's the B cell that remembered, oh yeah, right, I remember that tetanus. I remember that tetanus shot. That's what those cells are supposed to do. So basically, common variable immune deficiency is when there's not enough gamma globulin and there's not enough antibody, and the memory B cells have decided that they don't remember anything anymore. So how common is it? You know, I have no clue. I really don't know. The textbooks say 1 in 50,000. I personally know 600 patients at least with hypogammaglobulinemia. Last time I counted it was 600. And to me, I just don't think it's realistic to think that I've met 600 patients if that's really the number. I think it's more common than that. My bet is it's missed. I think people in this room could tell you, everyone here, raise your hand if you think that your diagnosis was missed for a while. Yeah. Well, this is what the books say, right? It says 6 to 7 years after the first cardinal illness that makes you think a test should have been done, it wasn't done, and it was delayed. It's 6 to 7 years. The longest I've ever heard about is probably around 20 years. I saw somebody recently that is probably at least 20 years. And so that's the other thing, is that if it's missed, then that means that, you know, how many more people out there really have this problem and don't have a clue about it? So I'm a little bit picky about the diagnosis, and I'll tell you why. Because sometimes the IgG alone can be reduced, and you may need gamma globulin, you may have a problem with making antibody, but for diagnosis of common variable, if you're going to talk about genetics and scientific work, we have to come to a decision about what is the definition. So this is kind of the international decision of what it looks like, realizing that it's pretty wobbly, actually. It's not wonderful. But the immunoglobulins, the G, the A, and or the M, in other words, 2 of those guys, one of them being IgG, have to be reduced. And the next thing is that the IgG is generally starting with under 400. That's for an adult person, by the way. And the other thing is that you have to show that that person has had a shot or a vaccination or has been ill with the disease and the antibody has not arrived. And that's important too, because it means the B cells could make a little bit of gamma globulin, but the stuff is a dud. It doesn't work, and that's important too. And then the other thing is, the last one is the hard one, exclusion of all other causes. And so, yes, you know, there's lots of other reasons why your gamma globulin could be low. So in the United States, this is the US IDNet Registry, currently holds data on around 1,700 patients here. And pretty much everyone kind of agrees that the IgG is nowhere near normal. By the way, the top of that scale at 400 is where normal actually would more or less begin. So these numbers are pretty low, and that's what's in the registry. And by the way, I hope everybody here is going to join the registry, because that's the only way we're ever going to know what are all the complications and how common they are, and what we tell the government about funding. Right at the moment, this is the only way that we have to really do that. Now, a very curious thing, which somebody could wake me up in the middle of the night and ask me why this is the case, and frankly, I don't know. How could it possibly be that a person who has very little, if any, gamma globulin, how could you possibly be an adult? But that's the case, which is most patients are not recognized nor diagnosed until the age between about 20 and 40. Yes, we have around 20% of my patients that have been diagnosed much younger, it's true, but average age is somewhat older, 20 to 40. So if you're in that category of, you know, your middle years, and all of a sudden somebody tells you you don't have any gamma globulin, it's a shock, a very big shock, but that's about what common variable looks like. Females tend to be diagnosed slightly later than males. I'm not sure why. So this diagnosis delay is something which is extremely troubling. Patients generally have to have 2 or 3 illnesses, ITP, hemolytic anemia, maybe a pneumonia here and there, the spleen is too big, the lungs aren't working, and then all of a sudden somebody decides to check out the gamma globulin levels. So why is it kind of difficult with you know, this naming? The naming's kind of tough. CVID is a diagnosis that people call it different things, and there's a couple of reasons for that. One is that your physician may have already decided that you need gamma globulin because your IgG is low, but I have to tell you, insurance companies don't like the diagnosis of IgG deficiency, and I've had that turned down. There is a code for that. It's just that they need to have this other name on the chart. They need to have it say CVID, and then they buy into it. So that's one reason. I think it's an insurance problem, to be honest with. It's not got to do with anything else. The other thing is that there really are overlaps between these diagnostic categories. In other words, your IgG can be low and your IgG2 can be low, and you don't make antibodies to some things, and it's not really all the way to extreme hypogammaglobulinemia. We don't have a lot of molecular methods yet to be absolutely sure. I'm going to come back to that. And then sort of differentiation from antibody defects can be kind of hard. And I always look at this slide and I think, I don't know if that's clear, but if you think that agammaglobulinemia, no antibody making at all, that red, and then you think over there in the pink end of that arrow, that's where antibody deficiency lies, specific antibody deficiency. In other words, you have immunoglobulins, but it just isn't very good stuff. But the question is, where do you kind of draw the line? Where do you say that pink turns into red? It's a little bit of a blur, isn't it? So this is kind of the way the biology actually is, and I think that's one reason that diagnosis is sometimes just a little bit tough to decide where you're going to cut it. Those are the antibody-making B cells down there on the bottom, and they're maturing in the bone marrow, and they go from 0 to, you know, all the way over into plasma cell department over there on the far side. But the break could be anywhere along that line. So one thing that always comes up is, how much testing do you have to do before you start to say a person is really immune deficient? Basically, we do a lot. I really like to know where a person started. I mean, I'm data-driven. I like to know, do you have antibody to measles, mumps, rubella, tetanus, diphtheria, chicken pox? Like, what do you not have? Pneumococcal vaccination, Haemophilus vaccination, hepatitis A or B. If all of those things really are not so hot, or maybe they're somewhat diminished, I kind of like to know where you started from. I think it's kind of useful to get a really good idea about that in the beginning. When a person's IgG is kind of higher than that, their baseline number, like 500 maybe, or 600, which is getting a little more into the realms of normal, I do a lot more testing, because we're making a decision that's going to affect you the rest of your life, right? When you go on gamma globulin, it's not because you become addicted to it. It's just that if the decision was made that you are deficient, it's not going to come back. So it's kind of nice to know, well, where did I start then? So we do a lot in the beginning, and we try really hard to exclude other causes. And then, of course, we do a lot of other testing as well, just to make sure other functions are pretty okay and there's nothing really that we need to know about. And then, of course, on a new consult, we try really hard to get all the previous records, so we, again, have a pretty good idea of the whole picture. And I think it kind of matters, because I think we want to put the diagnosis of CVID where it belongs if we can. And that becomes important when we're doing molecular studies and genetic studies, so we can all kind of say exactly what the picture looks like. So if the diagnosis isn't clarified at the onset, then, well, hey, you could be on the wrong treatment. Maybe you don't need gamma globulin at all. Every once in a while, I see a patient who's been on gamma globulin, but the original testing doesn't really confirm it. And I think let's go back. Let's dial back a little bit here. And then, of course, you might have side effects from the treatment. And of course, you pay a lot of money when you don't need to. And then maybe it's the wrong department. In other words, something else was really wrong, and you kind of put the diagnosis on there, but it's really not quite that. I guess the other thing, too, is that when you have CVID, then every doctor that you ever go to, even for stub toe or for hair loss or for fingernails that don't grow or anything, will be, oh, yeah, well, that happens in CVID, you know, and I'm thinking, not really. So let's not have everything hang on the same peg, I usually think. I've had people told they were CVID who they sold a business, for example, because they thought their life was in jeopardy. And they sold a business saying, well, if my life is short, I'm just going to go on a cruise for the next few years. And to me, that's not really what we need to do. What we need to do is get that person into optimum shape so that they can do what they want to do. If that business is pleasurable and makes money, why let it go? So I've had patients make very bad decisions because their doctor gave them the wrong information. Hopefully that's not the case for anybody here, and frankly, I think it's getting better, because I think CVID is getting to be better and better recognized. So I just put this one on because I know everybody looks everything up, right? I know you do. So do I, by the way. I mean, I look up things all the time. Somebody mentions to me a drug they're on, and hey, I have to go check it out too. So we're not any different. So what are the clinical features? Well, mostly it's this. Mostly infections, right? But then there's some other odd stuff on this picture here, which is that, well, there's a lot of autoimmunity. And again, don't you think that's very odd? You have a person who can't make an antibody to the measles, mumps, rubella, tetanus, diphtheria, chickenpox, or a pneumococcal vaccination, but they can still make an antibody against their platelets or their red cells. Anybody here had low platelets, ITP? It's pretty common, right? What about hemolytic anemia? Anyone had hemolytic anemia? Again, it's a very common thing and common variable. It runs about 20% of my patients, realizing, of course, I'm married to a hematologist, so I probably have a little bit of enrichment of patients with cytopenias or low platelets. So that's a possibility. But autoimmunity does occur, and you think, well, that seems so weird, doesn't it, that you can have a person who doesn't make antibodies against anything in nature but doesn't mind making an antibody against their own tissues. It is odd, really. And that's a whole interesting section of our field as well. Then, of course, gastrointestinal problems, enteropathy, where the GI tract just gives endless difficulty, diarrhea usually, inflammation and weight loss and that sort of thing. There's a few other things on that slide having to do also with lung disease, and PJ is going to get into some of those complications in a moment. If you're talking about infections, these are the common ones, mostly respiratory, sinusitis mostly, pneumonia, bronchitis. Some of the more uncommon ones are going to be shingles, which I think many, many people have had shingles. A lot of people have had shingles before I ever saw them. Meningitis and osteomyelitis is rare, but there are always going to be a few in any case series. In other words, severe infections of that sort. But not everything is infections, as I was saying a moment ago. The thing is, there's other things that worry us quite a bit, and I honestly think the reason why we're paying so much attention to these things now is because when gamma globulin was first introduced, remember that was around the middle, about 1985, it became reasonably widely available. IVIG and sufficient gamma globulin treatment, subcutaneous gamma globulin, has allowed the other diseases, the other manifestations to emerge. And so these now are the things that we pay a lot of attention to, because the infections we have a pretty good handle on, not wonderful, but better, I would say. And so what bothers us now? What do we worry about? What do you worry about? And that's what I'm hoping you'll put on your questions, by the way, is the things that you want to know about. What we concern ourselves with is lung disease. In other words, not infections, but when there's inflammation that will not stop in the lungs, even though it's not infection anymore, and we're treating that, it's an inflammatory lung disease. The low platelets, as I said a second ago, and low red cells. The spleen is large in around 20% of hypogammaglobulinemic patients. I don't care if it's large, I don't care if it's huge. It's a good filter, but on the other hand, it can be really quite massive, and the lymph glands can be really quite overgrown. And all of those things say that these are the things that we now worry more about, I would say, and try to come up with ways to combat that. So this actually makes me very sad, because this is a woman this is the first x-ray that I ever took on her. She's 28 years old. I saw her when she was first about 25 years old, came from Staten Island. She had never had a pneumonia that she knew about, but clearly her lungs have a tremendous amount of inflammation. And we call those little widened channels in the lung bronchiectasis. In other words, those little air tubes down there are all inflamed, and that's why they look like little tree branches down there. So that's bronchiectasis. And her immunoglobulins were almost zero. So here she is, 28. She's got no gamma globulin, basically agammaglobulinic. Now her lung disease actually was the thing that caused her death within about 3 years of this x-ray. And very, very sad, because I think she was basically missed. Nobody had a clue what was going on. She was also a smoker, but smoking doesn't do this. This is her low gamma globulins talking here. This is the autoimmunity slide. For me, it's about 28%. Most people, it's the platelets. That's that orange little area there. The next one is when the red cells and the platelets are both getting attacked by antibody. The next one around there is hemolytic anemia alone, where the red cells are the target of an autoantibody attack. So at least, about half of the patients that in this particular picture here have something wrong with the way that the immune system has attacked the other cells of the bone marrow, which is very, very odd. And we don't know the reasons for this. There's a lot of work that several of my colleagues have been involved in. Rheumatoid arthritis occurs. If you go down the list, you can see a lot of other autoimmune conditions there, some of which I'm sure people in this room have experienced. Again, it's this thing about how the immune system it's not a question of infection, it's a question of just getting misdirected. We spend a lot of time on the gastrointestinal issues as well. Mount Sinai happens to be the place where Crohn's disease was so-called invented. Burl Crohn was the chair of gastroenterology at Mount Sinai, and so we see a lot of GI disease at our place in general. But when you look at US IDNet and say, well, when you have common variable immune deficiency, what GI disease do you actually get? Sometimes it's just diarrhea, just a little excess diarrhea from time to time. But then with weight loss and with not keeping your nutrients in your body, and for example, having bones that become too thin, becoming anemic because you're not absorbing iron, all of those things get to be a much bigger problem. And so we spend a lot of time thinking about what are the best ways to treat the inflammatory disease. This is another study from US IDNet, and I'm sure somebody's going to ask the question like this, which is that, what about cancer? I mean, yes, there is somewhat of an increase in cancers. This taught me something, actually, this particular slide. We've always been a little bit more worried about lymphoma. Lymphoma in the European registry ran somewhere around 2%. 2% of patients, those were the ones that medical centers entered the data on, but you still have to put that in perspective. That's 98% chance against, too. Not 2% in favor, it's 98 against, actually. So the chances are rather small, rather tiny, a little bit more than normal people walking on the street. But the thing that I didn't know was that actually skin cancer was a little bit more common, too. And I'm just thinking, hey, I didn't know that. So I tend to recommend sunblock a little bit more than I used to. Don't get burned, Skin cancers are easy to treat. This had nothing to do with mortality here. This just means somebody registered, hey, they had a basal cell removed. All right, so we can use sunblocks. We can put on our hats, Is that different that we might say to any other patient walking into our office? Probably not. It's just we have to notice these things. Basic treatment, of course, everyone here knows this slide probably, which is that you have to be on immunoglobulin. You can give it every 3 to 4 weeks if it's intravenous. You can give it every week, or you can give it biweekly if it's subcutaneous. There's lots and lots and lots of methods of doing it. The companies make it a little bit hard to switch from one to the other, or I would say insurance companies do, because ideally what we would do, of course, is be on IV sometimes, and then maybe in the summer when we're traveling, go to sub-Q. Don't you wish that was the case? But it isn't, you know? It's kind of like you got to sort of be on one plan, and it's not exactly convenient for patients, I admit it. Of course, you can do it at home. You can self-infuse. For some reason, self-infusion in the United States has become a little bit less commonly done, but that's what Hans Ochs in Seattle had started a long time ago. If you have hemophilia, you can give your gamma globulin yourself. So why is it that patients who are on IV can't do their own IV at home? They probably could, and did in some original studies. I always put this on there, and I know that usually somebody will ask me about the port. We don't use ports when we ever possibly can. I don't like ports. Ports will eventually lead to trouble for almost anyone. Meticulous care is, of course, really important, but most people, even though they've been very, very careful, will end up having a port infection. And that, of course, is very risky. And I also don't like the idea of somebody having an indwelling piece of hardware if they don't have to, because there are alternatives, which is the subcutaneous treatment. So we don't use ports. Having said that, I do have a patient who does have a port who had a bone marrow transplant some time ago, and we simply haven't ever gotten the port taken out as of yet, but someday, of course, I would want to. So we don't like ports for lots and lots of reasons. Usually you don't have to have one, for one thing. And by the way, we don't generally use pre-medication. A patient told me recently who I saw who came to the office said that on Facebook, everybody is using pre-med, and I'm thinking, what? Why pre-med? Why do you want to use pre-med? I mean, I have patients who tell me that, please don't take my Benadryl away because I love the nap. And I'm thinking, okay, fine, have your nap, you know. It's okay with me, but it's not because of the gamma globulin. Maybe you need a nap, you know, and that's okay, you know. Most people don't need pre-med, basically. If you love your pre-med, then that's wonderful. But to be honest with you, sometimes across the United States, nursing is not aware that it's actually not required. This isn't chemo, after all. It shouldn't be taking, you know, 4 and 5 hours either. It should be taking reasonably length of time, would be more like 2 and 3, and maybe for very slow infusers, maybe 4 for a larger dose. But generally, it's not supposed to be like a chemo event that kills your day. So those are my kind of, you know, pet peeves, is when patients are told they have to have something, and the honest truth is that they don't. So, of course, with antibiotics, we culture wherever we can. It's not always practical, I realize that. Antibiotics are often needed. We use antibiotics a huge amount. I have absolutely no difficulty ordering any amount of antibiotics, pretty much. My friend Isabella Quinty put a paper out in the journal JACI about, I guess a month ago, that was a double-blind, placebo-controlled trial of azithromycin 3 times a week for 2 years in patients in Rome who were antibody deficient. And the bottom line was it was fantastic. It worked great. People's lungs were better. They didn't develop resistant organisms. So if you have a question about antibiotics, this paper actually says something very useful because it puts it down in writing, something that Dr. Quinty put a lot of time into, and I really am thanking her for actually putting that data down, because it was really a really nice way of looking at it. I think prophylactic antibiotics have been debatable, but this article really put something to rest. So I'm just going to talk a little bit about DNA and inheritance and testing. So first of all, I've been collecting and looking at patients with common variable immune deficiency for so many years, it's not even funny. I mean, some of my patients now are even, amazingly enough, you know, 30 and 40 years old, and I knew them when they were children. So it's kind of like stunning to me to be able to stand up here and tell you what I do know about that. I used to say that the inheritance in families was somewhere around 5%, because I couldn't think of any of my families in whom other members had subsequently been diagnosed. The numbers are very, very small. But if you look in the European literature, it runs about 10%. So the question is, well, what is it in the United States really? And then what about, how are we ever going to find out what is the inheritance of this? Will we ever define all the genetics of it? And then defining these genetic mutations, what does that do for us? Why would we want to know? Why do we need to know? So here's some answers here. So what proportion of patients? In my experience in the United States, it seems to be less than 5% will have another affected family member. Now, I will tell you that the genes that have been discovered more recently are those that we call autosomal dominant with variable penetrance, which means that another family member may have exactly the same gene, but it may not come to light. And so that is kind of the extra wrinkle on that comment. Will researchers ever define all the genetics? I don't know. Maybe not. I don't know. Will defining the genetics help us with individual patients and treatment? Yes, we think so. In some cases, it actually can be quite useful. It tells us what the path was that was actually misguided. And from that, we may be able to pharmacologically do something that's more pertinent in addition to the gamma globulin and all. And so should I have gene tests? If you've had some of those extra complications, it might be helpful. But still, you know, for about 70 to 80% of patients, we don't actually know yet what those gene mutations are, but we're working on it. So we've done a lot of genetics at Mount Sinai, and we've done now somewhere close to 300 patients. And the ones that we started with, the ones that I was worried about. In other words, when somebody told me they had more than one member of a family that was affected, naturally we looked for that. We looked for those that had very early onset. In other words, a person who was sick under the age of 10, we spent a lot of time on that. We also spent a lot of time looking at those who had extra inflammatory disease because I really needed to know what was I not doing right? What did I need to know? And then also for those with very low or absent B cells. And so this is actually the most recent slide, most recent data. It has not been published. It will be put out in a paper that I'm sandwiching with Swedish data, and it will be in Blood sometime later this year, which is about 29% of the time I can tell you what the gene is. Which to me, that I can ever tell you this, tell anyone in this room that, is totally astonishing to me, because that we actually know these genes now, and what it is that made this situation the way it is, I can actually tell you at this point in time. Now, the curious thing is that most of the genes are not those that have to do with B cells. Most of those that we see in the United States, people who do not have not got a family, have not intermarried. In other words, there's no consanguineous marriage. Grandmothers are not related, which is the way that it is mostly in the United States, with some exceptions, of course. It turns out to be genes that have to do with all of the upbringing of those B cells, how they were raised, their environment, the cells they came in contact with, the environment that they were with in the lymph node. So this slide right here is an attempt to sort of say that. I don't think I have a, did I have a, I don't think I had a, I was trying to look for a, a pointer. I don't think we have a pointer. But what the slide says over way on the left-hand side is the bone marrow, because B cells are born in the bone marrow. They become babies. They're babies in the bone marrow. And then what they have to do is they have to slowly over time receive signals to say, you may leave the bone marrow now, and then ultimately they go to a lymph node in your neck, in your spleen, wherever those lymph nodes are. And then that's where they meet the antigen that they're supposed to know about. It might be your arm. It might be a tetanus shot that you got. So the lymph gland underneath your arm is the place where that B cell got educated. And the next thing it has to do is it has to meet some T cells, then it has to meet some dendritic cells, and then it has to meet some chemical modifiers called cytokines. And all of these things mean that B cells just have a really, really, really hard life. That's the problem. 10% of them only survive. 90% of them don't, because their quality control is not good enough and they just die by the wayside. And all of those cells tell us why it is that the genes that we're seeing are really not B cells. They're everything else. So the life of a B cell is really a very hard one. And that's really all the genetic influences, and that's why we have somewhere around 50 different genes that means the B cells don't work. Now we can understand that. We never understood that before. So this is genetics, the big picture. So why would you ever get a test? Well, the pros are, over time, we're going to know more about B cells. And to me, of course, that's what I do. I'm extremely interested in why B cells work and why they don't. I have been ever since I did a Ph.D. on the topic of IgA a long, long time ago. Always been something I think is really fascinating. So it tells us about how B cells actually work. Number two, it might help with family planning. It might also tell you that if you have children, that you may or may not have a gene that we know in 2019 that you did or did not pass on to your children. So that's handy, it's useful. If there's inflammatory disease, it also might help you to know that there's another therapy that might help, because now we can sort of steer things a little bit better. So what are the cons? So the cons are, well, we may tell you we don't know. I say 80%, 70% of the time I would have to say, I'm sorry, I don't know, I did the test, we spent the money, but we don't know. So it can be expensive, yes. And then you are more than likely, likely to not find the causative gene. So that's a bit of a negative, right? And what are you going to do differently anyway? You're still going to be on gamma globulin. It's not going to change anything. You're still going to need antibiotics all the time. It's not going to change anything ultimately. Not going to alter that sort of stuff. And anyway, we can't fix the gene. So those are all the cons right now. So I find the question tough, but as I say, we're still on the borderlines of being able to really kind of dissect who it's useful for the most. And I think the jury is somewhat out on that. Now I'm going to turn it over to PJ, because now these are all the things that fret us and make us worry. And PJ is going to tackle that one.
Okay, that's a tough act to follow in the field of CVID, but I'll try. And what I'm going to focus on is really talking about some of the areas which I think there have been leaps and bounds in terms of our understanding in recent years, in terms of what we can do in managing. And these are some of the most challenging aspects of the condition. And so hopefully we can cover some new things. So when we talk about complications of CVID, what does that mean? What is a CVID complication? Well, we think about CVID as being, in some people, it's just results in infections, and patients will develop infections and no other complications other than that. But it's also notable that many will develop what we consider chronic and, in quotes, non-infectious complications, meaning that we don't believe or don't know that there's an infection underlying their condition. And this can include basically a list here, and in the right column gives you the percentage of basically how often this is occurring. And we see lung disease, chronic lung disease in particular, being among the most common, autoimmunity, which you already heard about, being very common, GI disease as well. And so and I'm going to focus on some of these more common conditions as we go forward. So when we talk about chronic lung disease, what does that mean? So on this slide are CAT scans, and I'm sure many of you in this room have gotten CAT scans before, and you might be familiar with what it is, but if not, on the slide you can see, and I wish I had a pointer to kind of illustrate this a little bit better, but you can see towards the middle of each of those squares, at the bottom, there's a spine. So you can think about going through the CT reader, feet first, lying on your back. And so the top of the slides is the top of the body, and the bottom is the back, okay? And then you can see that black area are the lungs. And what this is illustrating in A is an example of a bronchiectasis. And I'm contrasting that with the other boxes that illustrate other types of interstitial lung disease, which are other forms of chronic lung disease that we see in CVID. So bronchiectasis, as you can see, the white, which is the inflammation, contrasting with the black healthy lung, is localized around the bronchioles. And bronchiectasis is a consequence of chronic infection, chronic and recurrent bacterial infection, most typically, that is difficult to clear as a consequence of having antibody deficiency. And you can develop this complication, and that's one example of a chronic lung disease. Now, to contrast that are some other slides showing slightly different inflammation in the lung that may or may not be related to infection. And you can see quite a spectrum there. And I think the theme that we see when we're looking at CVID complications is that it's really never one size fits all. And there are a variety of complications and presentations that can occur, and we have to really appreciate the extent of the complications that we can see. So you can see towards the bottom left is really a quite significant evidence of interstitial lung disease, contrasting to some of the other examples. And you're not going to treat all these patients exactly the same. There's differences that are important to recognize and will shape management, and I'll talk a little bit about that. So at the bottom of, there's a term, GLILD, that many of you have maybe heard about that have had CVID, and that really allows, it's a term that really encompasses the broad presentations of interstitial lung disease. And that would be the examples of that you would see again at the bottom of this slide here. So there's a few key points that I wanted to highlight. So as was mentioned, there's been a lot of research in the past few years studying CVID, studying the complications. What do we know, and what's useful to take home for patients with CVID? And one of the points that I wanted to first highlight was bronchiectasis. And one question we often get is, if you have bronchiectasis, does that mean you're going to progress to interstitial lung disease? So I showed you these are kind of different types of chronic lung disease that have different treatments. And actually what our evidence shows is bronchiectasis is present in about a third of patients with interstitial lung disease, but it's not there in all patients. So it doesn't necessarily mean just because you have bronchiectasis you're going to progress to one of these other forms of chronic lung disease, and it's important for us to, again, think about every patient individually and what's going on individually. The next point that we often get is relating to infections. Because I've had a lot of infections, because I've had pneumonia, does this mean I'm going to get interstitial lung disease? Does this mean, what does this mean for my chronic lung disease? And for sure, there does seem to be an association between having had pneumonia and developing bronchiectasis, which makes sense because we believe bronchiectasis is really a consequence of infections, and chronic infections and difficulty clearing infections in the lung. Now, the interstitial lung disease that I showed you on that previous slide, those bottom two slides, in those cases, there are many instances where these patients haven't had pneumonia. So it speaks to a different underlying problem that I'll get to and I'll talk about a little bit more. And it's really related to this point. And one of the really interesting features that we'll see in patients with CVID that only have bronchiectasis and don't have these other forms of interstitial lung disease, they very rarely will develop splenomegaly and autoimmune cytopenias, which we heard a little bit about already, whereas those with interstitial lung disease do in many cases. And it speaks to that there may be an underlying immune dysregulation that really can lead to multiple complications. And it's an important thing to understand as we try to do better with diagnosing and treating these conditions, that there might be a common denominator that we need to better understand. Now, this is a point that was already mentioned, but I wanted to highlight it because, I think many of you in the room understand this, but there are many instances with other docs that have trouble wrapping their head around the fact that an immune deficient person can also have autoimmunity. When we think about immune deficiency being an immune system that's too low and autoimmunity being an immune system that's too high, how can you have both? Well, it's clearly the case, and it speaks to the complexity of what we're dealing with. Can't be so easily put into those categories. And the most common autoimmune conditions we see are cytopenias, as was mentioned. If you include certain types of GI disease into this category as well, you get even higher numbers. RA is quite common. And so this was a nice study that sort of highlighted this and really hammers home the data behind the fact that you absolutely can have both an antibody deficiency and an autoimmune disease, and it's important to be aware of that. Gastrointestinal complications are very common, and depending on how they're defined, reports include them anywhere in the range of 20 to 60%. And the typical symptoms that are encountered: diarrhea, malabsorption, and can even progress to troubles in terms of weight loss and more significant complications. These are the things that are faced. Now, in terms of the evaluation, the challenge is it could be a variety of etiologies. We could be dealing with infections that are acute or chronic. We could be dealing with other forms of chronic inflammation. Then the question of celiac disease comes up as well often in CVID, and I'll talk a little bit about why that is. And so in addition to stool studies, so looking for infections, which is a vital part of this evaluation, you're also going to want to really consider, and it can be very helpful, getting an endoscopic biopsy. That can be a really key point helping to differentiate between all these potential causes for your symptoms. And this is something that's often done and can be very informative. So I wanted to highlight celiac disease. This is a question that comes up quite frequently in CVID, and there's a reason for that. And it's because the biopsies from CVID patients can look very much like celiac disease. They have some of the same pathological features, which are defined by what we say are intraepithelial lymphocytes and flattened villi. That's the terminology that we use. Okay, and this is important to recognize because if someone is not familiar that CVID can give you this same pathology, they might recommend a gluten-free diet, and if it's not working, they might wonder, well, it should be working because you have celiac, and they may not, and it can be a very frustrating situation. And there is a blood test that we can use actually to help differentiate, and it can really be a useful tool if you're in that situation where someone has said you have celiac disease, you've done the gluten-free diet, it isn't helping you, and you're frustrated about what's going on. There might be a misdiagnosis, and there's some way to help with that. Now, the flip side of that is if there is benefit to the diet and you've been avoiding gluten and it is helping you, there's certainly evidence that even in non-celiac disease that it could help you as well. So I think the utility for evaluating this and really looking into the question is really for those that are not getting benefit and there's some confusion and that needs to be teased out. So we've heard a lot about sort of the complexity of CVID, and there's some people that are just get infections, and that's their main issue with CVID. And then there's many that are juggling a variety of complications, and it can really be very confusing. And how is it that someone can have all these things going on at the same time? Well, I think that there are some answers as we continue to do research on this topic and try to understand that many complications, or at least certain ones, can have perhaps the same cause, or they could have a similar common denominator that's leading to them that might explain why you're getting multiple things that happen at once. And here's some data that sort of illustrates that concept. So when looking at patients that had interstitial lung disease, CVID patients with interstitial lung disease, we saw a much more significant association with splenomegaly. And why would that be? I mean, if we're talking about lung disease and the spleen, they're often going together. So that speaks to there being a systemic immune dysregulation. And that helps to explain why does someone have so many of these things in different organs. It's because the problem isn't localized to one organ. And it's speaking to an immune dysregulation problem that maybe gives rise to a problem in multiple areas. And likewise, these patients with interstitial lung disease have more autoimmune cytopenias. Now, why is that? And we have studied this extensively, and it really, you see a lot of this of evidence of immune dysregulation that are the same. And I'll show that on this on a slide just after this one. But the point I really wanted to highlight is this might help make sense of why there's so many problems going on. Why do we see this? Because there's perhaps an overlap. Because we're seeing a lot of the same complications in the same patients. And so maybe there is an easier explanation. And rather than thinking about 3 different causes for 3 different problems, perhaps there is one underlying common denominator that's giving rise to these different problems. And that's what we need to target therapeutically to improve our care. And this is one other slide that sort of highlights that. When you're looking at patients with autoimmunity, and then you're looking at patients with this sort of benign lymphoproliferation that includes interstitial lung disease and granulomatous inflammation, you see a lot of the same characteristics of their immune system. So you begin to think, well, okay, maybe this explains why you see it's really, there's a fundamental issue that we need to be thinking about, and it maybe manifests slightly different in different individuals, and that could really be a key point going forward for our management. So what do we do about these complications in terms of monitoring and managing? And that's what I wanted to sort of talk about now. And so the things you can do include getting blood tests, and these are, in many cases, routine blood tests. CBC with differential can be very helpful to identify, is your platelet count normal, are you anemic, these key questions. A comprehensive metabolic panel can be very useful, particularly in those who have gastrointestinal disease. Do you have any kind of metabolic imbalance? Do you have liver disease? These are important things that can be as part of your annual follow-up and your routine visits. Your immune globulin levels, of course, are very important. They're important because we want to make sure that you're being dosed adequately. But we also understand that the dose is going to be different in different individuals. And it needs to be tailored to the individual. And in certain individuals with more of these complications that we've mentioned may need a higher dose of immunoglobulin. And that's important to recognize. And then there's going to be additional tests that will be tailored to the individual patient. For example, a patient with very significant gastrointestinal disease and diarrhea maybe needs to have more frequent monitoring of things like iron and fat-soluble vitamins and zinc. That might be really important for that individual patient. So blood tests can be very helpful. What do we do about lung disease? Well, a baseline CAT scan can be very important As I showed you, there are some very different presentations of chronic lung disease, and we want to help to really define what that is, because the treatments will be different, and I'll get to that shortly. Now, in terms of getting routine scans or a lot of CT scans, that's not something that we typically would recommend. What we do is really are going to follow it based upon your symptoms, based upon what was seen. Are we concerned about a particular finding, and we want to see how it changed over time? Are your symptoms getting worse? Do we need to look to see what's going on? That's the reason to get multiple scans, not like on a regular basis, regardless of what you're putting yourself through all these CAT scans. Now, pulmonary function testing can also be very helpful. And in particular, what we like to use are what we consider the complete PFTs, or a complete pulmonary function test, which includes diffusion capacity. And follow-up of this is, I typically do it more commonly because it's not as involved as getting a CAT scan involving radiation and all of that. It's a simple breathing test. But it's often dictated, again, by symptoms, by what's known. And then there are other tests that can be useful, even things like respiratory questionnaires, or doing things like the 6-minute walk test. Really take really give you objective findings to subjective symptoms. And it can help you follow this over time and seeing, is my therapy really impacting quality of life in a way that is useful to the patient, and to really understand, are our therapies working? As far as gastrointestinal symptoms, as I mentioned, endoscopy with biopsy can be very important for differentiating. There's a variety of certain pathologies that could be present. You can be dealing with infections and chronic infections. And the important thing to recognize is certain infections which aren't even treated in those who don't have immune compromise, things like Giardia, things like norovirus, can become chronic infections in patients with CVID. So that's an important and an empowering piece of knowledge to recognize that, Giardia may not have the same natural course in someone with CVID as it does in someone who just went camping and drank water and got a case of, that they're able to clear on their own without treatment. Same thing with certain virus infections now that we're seeing that normally aren't treated and now may need treatment. In terms of colon cancer screening, you just would follow current guidelines. There's not any reason just because you have CVID to get it more frequently or get it more often. Obviously, if you have a family history of colon cancer, the rules still apply, but there's no reason to change as far as we know. And then, as I mentioned earlier, blood tests are an important part of the GI monitoring, because they really give insight into, do you have any significant metabolic imbalance due to diarrhea or malabsorption. And so lastly, I wanted to get to, sort of what can you do? What are your expectations? What are the approaches you can take if you have any of these challenging complications? What do we do? And what's the standard of care? Now, bronchiectasis, as we talked about, is really an airway condition. And in many ways, you manage it not unlike asthma. It's a little bit different, as you can probably see on the slide. But the concept is very similar. You start off and you try, one intervention, and that's typically what we would think about is a patient's already on immune globulin, therapy. They may need to have an increased dose, potentially. But then you can add on some medications that are very similar to asthma medications, that are inhaled, that are like inhaled steroids, for example. You can use prophylactic antibiotics to prevent the exacerbations, which is another useful approach that has already been discussed and can be very helpful. And then what you do is you try to get by with the fewest number of interventions that work. But if needed, you just continue the cycle and you just come back around and you say, okay, we have to add on another therapy. And this is not unlike what goes on with patients that have asthma. You just have to find what is the treatment approach that will control this condition. And it takes a little bit of time sometimes. This slide has a lot going on, but the point is that interstitial lung disease is a complicated entity. And we need to gather as much information as we can in order to best treat it. And that's really what I want the take home from this kind of slide to be. It's a flow chart to just kind of show you that the important thing is we have to think about a few major points. Is the patient symptomatic? Is there evidence that the CAT scan or the actual lung process is worsening in terms of visually that we're concerned about, or the pulmonary function tests declining? And really, those findings are what are really key to justifying other interventions. And what you need to think about is the utility of a biopsy. And in an individual that's having a pulmonary function decline, it's having worsening of a CAT scan or the like, it can be a very useful approach to understand what exactly is this. Because not only does it help to differentiate between truly having interstitial lung disease or perhaps something else that's looking like interstitial lung disease on a CAT scan that would need a whole different type of treatment, it helps us to understand what type of lung disease you have and what the predominant cells that are there are. And what we actually recently published a paper on this, really showing that in patients that had a B-cell predominant interstitial lung disease, that they responded to B-cell depletive therapies. And that was informed by the types of what we saw on the pathology. And so that can be very helpful in terms of telling us whether it is interstitial lung disease or not, something else. Maybe it's an infection that looks like something like this on a CAT scan. But also it tells us, well, what is the nature of that interstitial lung disease? And then we can tailor therapy for that, which is really, really important. Now, as far as autoimmunity, the approaches are not unlike in patients who don't have CVID. Corticosteroids can be useful in the acute phase, but they're generally not a good idea in the long term. So you want to use what's known as steroid-sparing agents, which are numerous. I didn't list them all here. And then notably, I just wanted to highlight rituximab, which is a B-cell depleting agent. There's sometimes confusion about this because patients with CVID, well, they have antibody deficiency. And sometimes it seems like counterintuitive. Why would you deplete B cells in someone with antibody deficiency? But as you all know, it's not that simple. And patients with immune deficiency can still get autoimmunity. They still get hyperactivation of the cells that are failing them in terms of preventing infection. And notably, these therapies, or B-cell depletive therapy, can work very well for treating many forms of autoimmune disease in CVID. And it's worth considering depending on the nature of it, of the condition. And because you're on immunoglobulin replacement therapy, in many ways you might be the ideal patient to have your B cells depleted because you're already getting treatment for a B cell deficiency. As far as treatment for gastrointestinal disease, there is also a variety of approaches. You need to figure out, is it infectious, is it a chronic infection, and those need to be dealt with differently than if it's a non-infectious condition, where you might want to use a treatment like a steroid budesonide that's targeted to the GI tract, or other agents that will kind of treat that inflammation. You also want to think about, is there a consequence of the GI disease, a malabsorption that needs to be replenished? And that might require replacing things like calcium, zinc, or other vitamins. And then in some severe cases, you might actually need nutrition support, meaning you might need to get a peripheral nutrition, meaning you cannot get enough nutrition to sustain yourself just by eating. You need some kind of supplement, typically given intravenously, or it can be given by a tube, by a different type of feeding tube. So I wanted to end with sort of, in terms of this treatment portion, highlighting a particular case, which I think is important because, sometimes we're really faced with challenges, and we still are faced with a lot of challenges in treating complications of CVID. So this was a 26-year-old woman that we saw that really was coming in with, her major complaint was gastrointestinal, a lot of diarrhea, and based on the pathology and based on our concerns of her previous infections, we tried to tailor therapies the best we could. So on this graph, you can see that's her weight, and she's petite, but this is still really quite, her weight really did go down quite a bit. And then on the x-axis, you can see the days. You're seeing this is a long process, which is maybe not unfamiliar to many of you in the room, sort of the struggles that we face. And we tried a variety of therapies, and were met with some complications. And the therapies were again, as I mentioned, really rationally thought about. And the first therapy, she developed an acute, basically drug reaction to the medication. Then we had to put her on prednisone, and then we tried budesonide, and we tried other agents over time, and really, struggled to control her disease and to prevent her weight loss. Ultimately, she needed to be on TPN, which is total peripheral nutrition, just to maintain her weight. And so this is really, highlights that there still remains to be, many challenges. So despite our best efforts, we were really, having trouble understanding what was going on. Ultimately, with this patient, we tried a TNF-targeted therapy. Now, all the agents that I showed you on the previous slide, sometimes those will work in patients with antibody deficiency, CVID. Sometimes they don't. This agent sometimes doesn't work. Sometimes it does. In this particular case, it worked dramatically. And she had a very good response. She was nearly 70 pounds on TPN, so barely able to sustain herself, and then over time, over the course of weeks to months, gets off TPN and is now over, which is really at basically her best weight that she's been at. And I just wanted to mention this to really highlight that there's still so much that we don't know. There's still so much that we can learn from you and learn from our patients, and we're actively studying this particular case. Charlotte just actually helped me with a grant that I just put in on this actually gene that we found in this patient. And so, this is an active area of research, and it really requires a persistence in patients and really a team effort with the patients. And she is informing us about CVID as much as I have informed you guys today, probably more, and that's the important, it's really a two-way street. And so I just wanted to mention, as I was at Mount Sinai for a great time, I did my fellowship, my early, faculty time there, but as what happens with all great mentors, you end up going somewhere else. And so now I'm in Boston, and if there's anyone in that neck of the woods, I just want to put my contact information there. We have active research going on. We're enrolling patients, studying CVID, and so I just wanted to give, just a 2-second sort of pitch in that way. And so, feel free to, send me an email or, call for appointments.
Okay, so PJ's on a roll, so I'm going to give him the first questions.
All right. Okay, so this is a challenging question, but an important one, and one that I probably should have talked about. So the question is, when should spleen be taken out in a patient with CVID and low platelets? And this is a very challenging question, and I think my understanding is really this is the last resort. It's really something that it's really something that we try to avoid. It's not that it doesn't happen, and sometimes it does in CVID. The spleen just becomes so massive, or the issue becomes so much that it's affecting quality of life. But I would say this is an absolute last resort. Do you have anything else to add? Okay. I just wanted to keep going. Okay. Is bronchiectasis the result of continual infections in the lung, or is it the result of an inflammatory process related to CVID? So on the slides that I was showing, and I should try to show some of that data to kind of tease out that question, we do believe that bronchiectasis is a consequence of repeated lung infections, whereas the interstitial lung disease, we believe, is more due to an inflammatory process intrinsic to CVID, and that's why we see autoimmunity and enlargement of the spleen together with ILD, not the same way with bronchiectasis. Okay, should a person with a CVID also see heme as well as an immunologist? Well, I think Charlotte has a conflict of interest on this question. That's why she passed it to me. I think so, yes. I think, these are complicated cases that I think multidisciplinary approaches are important. You get more, sort of brains working on your case, the better. It can be complicated sometimes if if you have too many ideas and too many cooks in the kitchen, but I think in general, this approach works very, very well. And especially if your doctors are communicating, you really need to get them to talk to each other, share data, share notes, and be on the same page. And when you achieve that, I think it's the best choice.
Here's one for you.
Oh, another one. Okay. All right. Does a bronchiectasis automatically worsen over time? I would say no. There's actually evidence that with IgG replacement therapy, as well as prophylactic antibiotics and some of the therapies that I showed that you can actually halt that direction, and it doesn't have to worsen over time. Why are some immunologists hesitant to use antibiotic therapy? Well, so I think the concerns are valid to some degree. There's obviously concerns about drug resistance, but as was mentioned in the latest study, there doesn't seem to be as much drug resistance being born out of patients that have immune deficiency. It might be because there's an absent sort of immune system pressure that is driving some of that resistance maybe. But also we're learning more about the microbiome. And there are healthy bacteria and good bacteria and that die as sort of a result of sort of, being on antibiotics that can cause problems. So I understand where they're coming from that perspective. And then number 3 is what is the dose level if you have CVID and bronchiectasis? I think that's, and so that's, in terms of the antibiotic dose level. So it depends, and I think it depends on which antibiotics you are able to tolerate. We typically use macrolides, so that's azithromycin, clindamycin. That family works pretty well because it has a secondary benefit of being anti-inflammatory in the lung, independent of its antimicrobial function. So it's usually a good option, but it can have some GI upset associated with it, so not everyone tolerates it well. And what we typically do is we would do a 3-day-a-week dosing with that, and so you don't have to take it every day, and it works pretty well.
Okay, a bunch more. Okay. Let's see. So I'm just going to try to knock off a few of these. Is CVID more common in Caucasians? The data, unfortunately, has been collected more in Caucasians, so my bet is that we don't really know the honest truth of that. But I know that Harry Schrader at University of Alabama at Birmingham has said that he does not think it's as common in those of African American descent. So it could be that that's true. In New York, you would think that I would have equal opportunity to have made the diagnosis, and everyone in my cohort, again, it's Caucasian predominant. In Asians, whether it's common or not, I really don't know because I think the data just isn't good enough to say. It's possible that it's somewhat of a Caucasian gene. What we do know is that IgA deficiency is reasonably uncommon in African American. We do pretty much know that. Also in Malaysia and in Japan, because people went to the blood banks and actually said IgA deficiency is actually pretty uncommon. It's 1 in 14,000. In Finland, it's 1 in 400. So clearly, there are some genetic differences, and I do think perhaps if IgA is a stalking horse for CVID and they kind of sort of are related, I sneakingly feel that it is more or less a bit of a skew there. I wouldn't be able to tell you why, but what's my opinion on a child outgrowing CVID? That's a tough one because a child under the age of, say, 4 or 5 is somewhat immature, and it could be the immune system isn't fully formed. So if somebody says it's CVID under the age of 4 or 5, I'm always interested in making sure that that's the case. You can usually do that not too difficultly, even if the person's on immunoglobulin, because if the IgA and the IgM begin to rise, then you have a pretty good idea that the B cells are not out of business. And so I don't think actually people outgrow CVID as far as I know, not what's real CVID anyway. I've been diagnosed with CVID for 25 years. Do I need to ask for a more specific diagnosis? That's a tough one. I think if you're talking about from a genetic point of view, you could, in theory, do that if there's a particular reason for it. If everything is going quite well, I don't know that you necessarily want to spend your money on it unless it's more or less of a family question as well. More specific diagnosis would be, for example, if your IgA and your IgM are actually quite normal, you might really have IgG deficiency instead. We published a paper last year that contrasts IgG deficiency and CVID, and there really are quite a few differences. For one thing, the complication rate, the things that PJ was talking about a moment ago, are much, much, much less common in people with just the IgG deficiency version. It's all treated with gamma globulin. It's just that there does seem to be kind of a difference between B cells that really don't make much of anything and those that do a lot better. Is the TACI gene associated with CVID? In my view, yes. About, I think, 10 to 15% of my patients actually do have a mutation in the TACI gene. So the answer, according to me, is yes. But it isn't the only game in town. There's other genes as well. And the other thing is that I've seen a couple of patients who are homozygous loss of TACI gene, in other words, 2 homozygous genes, who are not immune deficient. So it's clearly not the only pusher. I think it's an influencer, though, for sure. What's the chances that you'll pass it on to a child? That depends entirely on the genetics that's present. if I simply took everyone that I've ever met over the 600 patients or so that I know about, it seems as if those who actually have a symptomatic child is probably somewhere on the order of 5%. So it becomes pretty unlikely in the United States. The European literature is more like 10%, but even there I think their data is a little bit confusing, partly because they have a lot of consanguineous marriages still in some of the cohorts. There's another one here, typical lifespan of a person with CVID. If you are a person who just is on decent doses of gamma globulin, your levels are good, that you are not running into medical problems such as other life-threatening diseases, hypertension, diabetes, arteriosclerosis, things that everyone can get, not just yourself, just human diseases. As far as I can tell, those who have the infection-only phenotype have exactly the same lifespan as your next-door neighbor of the same age. And we publish that data. If anybody ever needs that for insurance statistics, I think it works. Someone asked, in this era of molecular testing, why can't more than 30% get a genetic diagnosis? And why wouldn't we do whole exome sequencing? Actually, the data that I gave you is whole exome sequencing right there. It's just that when you're looking through 600,000 genes, and by the way, we're doing whole genome sequencing as well, which means even the coding and the non-coding elements, we don't always know what every single gene does. Remember that. When the International Union of Immunological Sciences re-met this year in New York, we added 30 new genes that we now know do cause immune deficiency, but they've recently only been identified as being even involved. So we don't know what every gene does. That's the problem. And it could be it's just really in there. It's just that we don't know the name of that one. Somebody says, how do you classify CVID for missing B cells? Marginal zone, memory, and class switch. We do that a lot. I've done at least 500 or 600 of these classifications. It's interesting, and when you have very, very, very low numbers of isotype switched memory B cells, those are the ones that are memory, and the ones that said, I'm ready for business, that's what that means, then that means that you are more likely, very much more likely, to have had either autoimmunity, a very large spleen, or some of the other complications that PJ was just now mentioning. So we do know that there is a very distinct difference between people who have a lot and people who have hardly any. And that is true. It doesn't do a huge amount more for you because it doesn't tell you anything more about what you need to do about treatment. So I'm going to turn it back over to some more complicated stuff too.
Which one do you want me to do?
This one was just in line of one you were doing a moment
Okay.
ago.
All right. So outside of IgG treatment, can a health diet help boost immune system? Things like low sugar, low carb diet, etc. So this is a great question. Unfortunately, we just don't have studies that really address it. And I think the general rule of thumb is having a healthy diet likely helps, but there isn't strong data that we can point to and say this is the diet you should adopt or these are the things you should include in your diet. Are there any nutraceutical supplements of value? Again, we have not done the studies to really, to actually know yet, to really be able to give guidance on that. But I think they're really important questions. Can a bone marrow sample help diagnose CVID? Well, technically, it could help in the sense that many patients with CVID have absence of what's known as plasma cells, which are the antibodies producing cells of the antibody factories that live in the bone marrow. But I would never recommend a bone marrow solely for the purpose of diagnosing CVID because it's far more invasive than is necessary. But if during the trials and tribulations of working up what's going on, someone did a bone marrow biopsy, you might want to, it could be useful to look, are there normal numbers of plasma cells there? And then here, if ANA, anti-SSA are elevated for the first time after you start SCID, is it important, or is it likely the IgG? And I think this is a really important point, that you can have, some of these autoantibodies that are used to diagnose autoimmune disease can be present in the immunoglobulin replacement therapy. And they don't indicate disease, and they don't indicate that that you'll get the disease as a consequence of being on this immunoglobulin therapy. So I would say no. And then all my scopes show cobblestoning of the GI tract. Diagnosis diagnosis is known as a microscopic colitis. Should a biopsy be performed? Oh, I see. So they've done scoping, but they've never actually biopsied. I mean, I would think that there is utility to this, but there's a way you can approach this. So you see that there is typically the treatment for microscopic colitis would be taking an oral steroid that is released in the GI tract, and if that improves the condition, then I think you can get by without getting a biopsy. But if that fails to treat it, I think there really would be use in actually getting a biopsy and seeing what is going on there.
That way we don't do them twice. Throw them down here. Okay, this is a tough one, and I feel bad about this one. Is lung replacement or transplant a viable option for CVID patients with bronchiectasis? I have unfortunately got 2 patients right now who are 6 months and 3 months post-lung transplant who are still in the hospital and had lots of complications. So at the moment, lung transplant and CVID is something that just gives me the shudders, actually. I don't know how either of them are going to do at this point in time. I'm pretty unhappy about that. One of the sisters of a patient of mine had a lung transplant in Pittsburgh last year, and that patient is no longer alive to tell about it. So, no, it's not my favorite idea. Okay, a lot of gamma globulin questions. IVIG is the fix for CVID. Yeah, sort of. It's not a fix, but it sort of brings people up to a certain level, right? It's expensive and long-term. What else can be done to fix the low IgG? To be honest with you, we don't know. Can't make those B cells restart as far as we know. There has never been a situation in which that was possible. When they've decided they don't want to do it, I don't know of any way to make them want to do it again. What's the desirable level of IgG while you're on gamma globulin? It used to be 750 plus, now it's more like 1200. Hey, nobody made that rule, really. You can read it, all the idea is just kind of a guidelines. You want to have plenty in your blood, but nobody made a fixed level. In fact, there's a paper from Helen Chappell and her group that said that when you have a physician who's going more by infections and by the actual patient, the level can vary quite a bit. So making an arbitrary number is tough. The other thing is that suppose that you are a person whose IgG started at 300 or 400 and you had some functioning antibody in your original production. You know, now what we're doing is we're topping up the tank. So if a person starts at 0 and gets to 750, that means they're 750 to the good. If somebody is starting at 300 and you give 700 or so, then of course they're going to be more like 1,000. So it also depends on your starting level and how good the original starting level stuff was good or not. So in other words, you kind of need to have a little bit more of a open picture based on that individual person, not saying, hey, it's got to be 1,200, forget it, and that's it. There really isn't an individual number that one could make. Why do we treat IgG but not IgA? We don't know how. Simple, very simple, don't know how to do it. But then you think to yourself, well, if 400 people living in Finland is IgA deficient and never had any IgA, I think the Finnish and the Scandinavians are pretty strong people. They seem to manage without it. So evidently, we don't really have to have IgA to be in good shape. And IgG does pretty much everything IgA does, except, of course, it doesn't go to the mucosa particularly. Are immunizations still helpful to people who have CVID, and if so, which ones? That's a tough one. We usually do give flu shots because it teaches your T cells, right? So we give flu shots ourselves. The other immunizations, you don't need them, but most recently, I don't know if you know, there's a new shingles vaccination that's come out. It's dead. So the new dead shingles vaccine, I have been suggesting patients could get it because, again, it's much more of a T cell dependent. Not getting shingles when you're on gamma globulin is really uncommon, but I have seen it, and shingles shot is not a bad idea. So shingles in that one is okay. I don't think a live virus is a good idea. I've had patients tell me that they want to go to, for example, Kenya, And for that, you have to get yellow fever. So usually I write a note and say they can't get the live virus vaccination. It could be I'm overcautious, but anyway, why have a problem? Is it easier to get sepsis if you have CVID? If you're on gamma globulin, it's pretty hard to get sepsis. If you're not on gamma globulin and you don't have antibody, it would be pretty much something that could happen. We've all had septic patients who have hypogammaglobulinemia before treatment, not afterward. If your levels of gamma globulin are 1,000 or 1,100, do you need to stay away from somebody who is sick? That's an interesting question too, and generally I would think not. I mean, I have patients of mine who are very hypogammaglobulinemic who are either in medical school or already doctors. And so if you think a doctor who's hypogammaglobulinemic on treatment could go out and see patients, then what would be the problem with that? So I don't have a reason to think that that would be an extra risk. Another tough one, type 2 diabetic on pumps for 32 years and bad veins, would it give a port? I'd sure try not to. Last thing that person would need would be one more indwelling item, let's put it that way. So I would try not to, realizing there's no absolute answer in medicine for any question like that. There's no absolute. Pick up a pile.
More? Okay.
Pick up a pile.
This one right here?
Yeah,
Okay, picking up a pile at random here. So this is, I think a lot of these questions are better than we get at scientific conferences. You know, they're like, I feel like, so this one's really good. It's wondering how often in CVID do you have problems with the kidney, autoimmune kidney diseases, and I think that's a question that we talk about because, why does the autoimmunity affect certain compartments more than others? I think this is an active area of research. I know Charlotte has a patient who has kidney involvement and CVID, so it isn't unheard of, but it does happen less commonly than, say, some of the other autoimmune complications. So I think it speaks to what that V stands for, and it's variable, and so everybody really can present differently, and it just depends on the nature of your immune defect. So the answer is I guess it's not many, not as much as the other complications, but they definitely happen. I have long-term Lyme disease and CVID. Has the relationship between these diseases been studied? I don't believe so. And that's as far as what the CVID immune effects relate to Lyme, I don't think is really well described, unfortunately. Can you use a long-term antibiotic for Lyme? Would that hurt gamma globulin production? No. I think it is safe to use antibiotics. It's not going to hurt any normal function of the way that your B cells are going to function normally. Is there a connection between MGUS, which is this condition of a monoclonal gammopathy? Did you want to answer this question? I know this is like kind of an interest of yours, a little bit.
That's a tough one.
But
Well, I don't think there's not exactly a connection, but it could be that if you were making a protein that's useless, like a myeloma protein, that it could be that the good antibody-making cells are really not working very well either. And so I wouldn't call that CVID, but I would say that person was immune deficient, and they may very well be on gamma globulin. That's one thing. The other thing is that a person with CVID also, slowly over time, might develop a protein in the blood, which was one clonal group of cells that decided to grow up faster than the others, and that would give you a monoclonal protein. So that would be kind of like an overlap situation. So if that person has that question, wants to get a little bit more detailed, we could probably give a better answer about that. This one is elevated liver enzymes. Elevated liver enzymes in CVID, these days, we usually have now ascribed to a condition called nodular regenerative hyperplasia. It's very, 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 very common. To really diagnose it, you'd have to have a liver biopsy to say. There is no treatment for it. We don't know what to do for it. The liver can be definitely enlarged. It's something to know about because it can cause you to have portal hypertension, which means the spleen is big, but the blood flow between the spleen and the liver is quite congested, and that can be kind of a problem over time. So anyway, you might, if this question belongs to you and your liver functions are slightly off, get your doctor to read the articles on nodular regenerative hyperplasia. A couple of questions on antibiotics. Azithromycin versus Bactrim. Bactrim's a great drug. Don't misunderstand either of us. It's a great drug. If you've been on it, it's satisfactory, you're not allergic, no difficulty. It's very, very good for lung disease. You can take 1 double strength 3 times a week. It's a very, very successful treatment as well. I think PJ mentioned the anti-inflammatory effects of the macrolides. That's the azithromycin family. So that's the other reason that we often use that one instead. But Bactrim's a very, very good antibiotic as well. What do you do if you need an antibiotic in the presence of an active infection in a patient with a history of C. diff? That's a tough one. C. diff doesn't seem to be incredibly common in hypogammaglobulinemia, but we've all seen it. And yes, it's a tough one, and I'm not going to be able to give you a wonderful answer on that one. You're going to have to use shorter courses and hopefully the most correct antibiotic for the situation in hand. And you may have to use the vancomycin as well in order to keep that at bay. And that was the question somebody else asked. In other words, something about the continuous use of vancomycin. Again, try very hard to make sure that the cultures are positive. If they aren't, it may be actually another bacterium that's present. Primary care and urgent care providers usually say, it's a virus. I know. I know, it drives you crazy, right? And what can we do to change that? Not much, because viruses do occur and we don't know how to tell what's what. I mean, I've looked down plenty of people's throats over years. I can't tell if it's a virus or a bacteria. Doctors can't tell the difference, frankly, let's be honest. So we usually try to culture and do what we can. If you have CVID, though, to be honest with you, urgent care is never going to be your best friend because they don't know what you're talking about. So, that's a tough one, right? Do prophylactic antibiotics cause gastrointestinal damage? Not that I know of. I don't think that they do. You can read that report of Dr. Quinty if you want to read it. I can give you that reference if somebody wants to have it. She's the one who did the study on the azithromycin in Rome. Are zebras becoming more allergic to antibiotics? If yes, what to do? I don't think so, but I haven't really kept a track on that. You have an opinion? Not that I'm aware of. But individually, I mean, we all have patients who can't take certain antibiotics, that's for sure. We only have a couple of more minutes. If anyone wants to stick around for the last couple little lightnings round here, we'll try. Lightning round. What is the registry? By the way, that's the registry, US at IDNet.org. Some of the team from the Immune Deficiency Foundation's registry are here. What the idea is to collect data on 6,000, 7,000 or so patients with primary immune deficiency of all categories. Common variable immune deficiency is one of the biggest categories. You have to give permission for us to have your data. We like your medical data, but we also like to have, all the things about you that are the demographics. I mean, somebody asked the question about Caucasians and CVID, for example. How can I really answer that unless everyone is entering the registry? I really can't give you a good answer. So really, we depend upon you for that. Let's see, do vaccines do anything? I think we already went through that, right? So you don't need the other shots. You don't need tetanus. You don't need pneumovax. You will be immune to measles, mumps, and rubella. And if your doctor needs to know that, they can take a titer. And in fact, sometimes for people who don't want to get an extra vaccination, if you simply take a test for protectivity, you will find that you are protected. And you can use that on anything that you need for school or for entrance exams or for nursing or education or anything else. You will find that you are immune and you can substitute that. You don't have to give the date of the vaccination. You can just simply show the laboratory showing you are in fact protected. If you had a childhood disease such as measles and mumps and rubella and such, and you had it before, let's see, how do I'm sorry, I don't quite get this. If you have CVID, would your system remember it? It might, your cellular immunity may actually recall those diseases. We can't test for that because that would be in your T cell department, so we don't have a very good way of testing for that, but you may still have some immunity that your immune system remembers somewhere in that department. I think we did lightning round. If we missed anything, you can ask us now. Okay, there we are. This is the Game of Thrones here, okay? House of B cells.